Welcome to Orthodontics Explained, the podcast where we break down complex orthodontic concepts into simple, practical lessons for students and young clinicians. Today's episode is all about anteroposterior discrepancies, what they are, why they matter, and how orthodontists correct them. We'll go step by step, covering molar distalization, protraction, uprighting, and even molar rotation. You'll have a complete roadmap of how we bring molars and bites back into harmony. Section 1. The Foundation. Class 1 versus Class 2. Let's start simple. A Class 1 molar relationship is the orthodontic gold standard. It means the upper and lower molars interlock properly, giving us balance, function, and stability. But when the upper molars are too far forward, we call it a Class 2 relationship. Left untreated, this can cause functional problems like poor chewing efficiency, aesthetic issues with the profile, and instability in the bite. So how do we correct this? We can, 1. Move the upper molars backward. That's called distalization. 2. Move the lower molars forward. That's protraction. 3. Or sometimes, we do a combination of both. Section 2. Molar distalization. Gaining space without extractions. Now, let's dive into molar distalization. One of the most common methods to fix Class 2 relationships. The goal is usually to gain 2 to 3 millimeters of space in the arch. It sounds small, but in orthodontics, every millimeter counts. But before deciding to distalize, the orthodontist checks a few key things. The angle and rotation of the molars. Whether there's space for second and third molars. The patient's growth pattern, low angle, normal, or high angle. Here's the catch, timing matters. The best time to distalize is during the transitional dentition, before the second molars have fully erupted. Why? Because the bone is more responsive and movement is more stable. If you try it after second molars are in place, the molars may tip distally, creating instability and risk of relapse. That's why, in those cases, we often include second molars in the appliance to move them together with the first molars. Section 3. Techniques for distalizing molars. So, how do we actually push molars back? Let's break down the main techniques. 1. Headgear. This is the traditional method. Works best in low or normal angle patients. Requires serious patient cooperation. Ideally, 16 hours a day. With lighter forces, 330-50 gaze, we move teeth only. With heavier forces, 400 to 600 gaze, we can influence skeletal growth. But because it's removable, it often causes molar tipping unless carefully adjusted. 2. Microimplants or TADs. These tiny screws give us absolute anchorage, which means no other teeth move while we distalize. They're usually placed between the first molar and second premolar, or in the mid-palatal suture. Force is applied through springs or jigs, keeping the movement close to the center of resistance. Once distalization is done, the same implants can be reused for anterior tooth retraction. 3. 2x4 arches. Common in children. Can tip molars back, 1-2 millimeters, which may be enough for permanent teeth to erupt. The drawback? It's unstable and relapse is common. 4. Nance appliance with coil springs. Uses premolars and a palatal acrylic button for anchorage. Works, but anchorage is not perfect. Often the incisors protrude as a side effect. 5. Superelastic night T-wires. Pre-activated wires apply a gentle, steady force of about 100 grams. On average, molars move 1 millimeter per month. Class 2 elastics are often added to prevent anterior teeth from flaring. 6. Sliding jigs. A simple stainless steel wire device that directs elastic force straight to the molars. Effective in both transitional and permanent dentition. Can slightly widen the anterior segment, but stiff wires help prevent this. Each of these methods has pros and cons. The choice depends on the patient's growth pattern, compliance, and long-term stability goals. Section 4. Molar protraction. Moving teeth forward. Sometimes we need to move molars forward instead of backward. This is protraction. It's easier in the maxilla because the bone is less dense. In the mandible, the strong cortical bone and powerful chewing muscles make it harder. Protraction is also more effective in younger patients, since their bone adapts more easily. The mechanics include using stiff stainless steel wires to avoid molar tipping, adding Class 2 elastics for anchorage, and often reinforcing with microimplants for direct, controlled movement. One important clinical note: in high-angle patients, protraction can worsen the vertical dimension by opening the bite. To prevent this, orthodontists may combine it with intrusion mechanics or posterior bite blocks. Section 5. Molar uprighting. Fixing tilted teeth. When molars lose their neighbors, for example after an extraction, they tend to tip forward into the space. This creates occlusal problems, joint stress, and even bone loss. To upright molars, we can use straight wires, cantilevers or loops, or microimplants in the retromolar area, which allow uprighting with or without intrusion. The tricky part is controlling vertical movement. Many uprighting mechanics cause extrusion, which is harmful in high-angle patients. By combining with intrusion forces or using TADs, we can upright the tooth while maintaining vertical stability. Section 6. The rowboat effect and molar rotation. One side effect of uncontrolled mechanics is the rowboat effect, when a crown swings undesirably due to bracket angulation. To avoid this, orthodontists stabilize the canines with strong anchorage, often reinforced with TADs. Another common correction is molar rotation. A rotated molar can waste 1 to 1.5 millimeters of space per side. Correcting rotation not only frees space, but also makes anchorage more efficient. The tool of choice here is often a transpalatal arch, which gives better three-dimensional control than a simple flexible wire. Section 7. Clinical pearls. To wrap up, here are some clinical pearls for students to remember. Always match the technique to the growth pattern. Control the vertical dimension, especially in high-angle patients. Start distalization early, before second molars erupt. Reinforce anchorage when needed. Headgear, elastics, or TADs. Reduce friction by polishing wire ends. Use segmented mechanics when you need precision. Conclusion. Correcting anteroposterior discrepancies is about more than just moving teeth forward or backward. It's about timing, anchorage, and biomechanics. Distalize molars early and with control. Protract carefully, especially in the mandible. Upright molars to restore function. Rotate them to unlock hidden space. Remember, in orthodontics, every millimeter counts. By mastering these mechanics, you'll build treatments that are not only effective, but also stable and long-lasting. Thanks for tuning in to Orthodontics Explained. If you found this episode helpful, be sure to share it with classmates and stay subscribed for more clear breakdowns of orthodontic concepts.